All right. Hello, good afternoon or good morning, everyone. Welcome to Conversation 3, Staffing and Legal Services of a Medical Legal Partnership. Should we directly hire a lawyer or contract with another organization? You are joining the National Center for Medical Legal Partnership in partnership with Texas A&M's Institute for Healthcare Access and our lead faculty for the third part of our webinar series, helping health centers plan, implement, and practice medical legal partnership. Welcome back again. Today's March 14th, time's about 1 p.m. on the East Coast. Let's go to the next slide. All right, quick housekeeping. As you all know, we've joined on Zoom, and so you're automatically muted, but this is a very interactive webinar, so please feel free to use the Q&A function to send questions to us as soon as they arise. You don't have to hold on to them. Use the Q&A to send your questions, and we'll certainly get to them. But then also feel free to use the chat if you want to engage with each other, if you want to send us messages as hosts, if you need some assistance. And yes, we will be recording today's webinar and sharing both the slides and the recording on the Medical Legal Partnership website. We'll ensure that everyone has access to that link in the follow-up emails. And you can always reach out to us if you need help finding the page where these webinars will be housed. If you do need to see captions, you can activate the captions today by selecting live transcript and then show subtitle in the Zoom more options. Let's go to the next slide. A little bit more housekeeping, because I mentioned that this is interactive. We really do want to hear from you. So at certain points during the webinar, you'll hear one of our primary faculty members actually ask everyone to raise your hand using the Zoom functions to unmute the microphone, and we'll unmute so that we can invite you to speak and share your response to the discussion question. So get ready to talk to us again. We really like to have more interactive learning and training sessions here at the National Center. Let's go to the next slide. Something else that we figured would be particularly helpful as we continue to make our way through this webinar series is providing folks with a little bit of a glossary or definitions regarding the alphabet soup that you'll hear us increasingly use, perhaps for efficiency's sake, or to better align with the lingo that you're using in the field. So you'll hear us absolutely interchangeably use MLP and medical legal partnership. But you might hear us refer to health centers or community health centers, and occasionally see on documents and resources or on slides an abbreviation CHC, or you may see the more formalized FQHC if they are receiving a Section 330 grant and taking part in that program, or FQHC lookalikes, FQHC being federally qualified health centers. You will also hear us referring to HRSA, or the longer full title, Health Resources and Services Administration, which administers the health center program. And then also for those in the legal services or legal aid world, you'll hear us referring to the largest grantee of those organizations, LSC, or the Legal Services Corporation. So let us pause at any time if you need us to stop and define some of the delicious alphabet soup that we will be serving up throughout the webinar series. Let's go to the next slide. As folks are joining us, I just want to provide a reminder that this entire webinar series is a project that's supported by the Health Resources and Services Administration, or HRSA. The National Center is in its 10th year of funding under a cooperative agreement to provide training and technical assistance. So thank you to HRSA for allowing us to have the funding and support to provide this training to MLP practitioners around the country. Next slide. Again, this is a webinar series that we launched in February of this year and are continuing all the way through June. So there's several more webinars coming up. The National Center is partnering with Texas A&M's new Institute for Healthcare Access, led by Keegan Warren, who's joining us today. And we are utilizing the Health Center MLP Toolkit as the resource for this series. There's several points you may see in the webinar, our lead faculty referring to the Health Center MLP Toolkit, or you'll see an icon so that you can continue to use it as you then apply the learning on the live webinars to your day-to-day work. And for each webinar, again, we're going to call on folks to engage with us either through polls or through unmuting and sharing your thoughts. Let's continue. And speaking of engagement, we have the very first poll. So I'm going to launch the first poll. Let's see here. I'm going to ask Reha here at the National Center if she can confirm that the poll is live. So you should see 3 questions on your screen as participants. And the very first question is just finding out who's actually joined us on today's live session, session number 3. Are you from the healthcare sector, legal services, or other? See, responses are coming in. Second question is, does your organization have a medical legal partnership? So it's helpful for us to know where our learners are in terms of knowledge of MLP. And then finally, as it pertains to this specific session, we'd like to know, how do you staff the legal services component of your MLP or medical legal partnership? Do you directly employ the legal team, whether it's a lawyer, paralegal, or other types of folks like community justice workers? Are you contracting with another organization? Are you using some hybrid of these 2 approaches? Or are you still in the development stages? Let's see, we've got about 85% participation. If you haven't answered yet, I'm going to count down 5, 4, 3, 2, 1. We got a few more responses in there. I'm going to end the poll, and we should have the results showing on the screen. So about 57% of you are from legal services. I want to thank you all for joining us again. And then the remaining portion are about 30% from healthcare, and then 17% from other. We have 72% of y'all with medical legal partnerships. I really want to thank those who continue to join us, even though you have an MLP, because that means we're able to provide you with some assistance on perhaps improving or building upon what you've already established. So thanks to those who are not at the very beginning stages. Also, thank you to those, but especially those who already have an established MLP. A lot of you are using the contracting model. So about 44% of today's attendees are contracting with another organization that provides legal services to staff the legal services component of their medical legal partnership. When you hear from our lead faculty, Jay Siklik, about the various models, please, it'd be really helpful for us to hear from those who are directly employing the legal team, about 22% of y'all, as well as contracting with another organization, to better understand those distinctions. All right, let's continue. Next slide. All right, as mentioned, we are in conversation 3 of the toolkit, where for the webinar series, let me get rid of the poll on the screen. Sorry. So we're in conversation 3 of the toolkit, which aligns with today's webinar on staffing the legal services of an MLP, helping folks understand if you should directly hire a lawyer or contract with another organization. Next slide. All right, and today's learning objectives are on the screen. Number 1, we're hoping to help everybody better identify the specific model they want to use to employ in their MLP with some historical perspectives. Number 2, we're going to compare and contrast the direct services and the contracted model for MLP staffing. And then number 3, we're going to explore some variations and implementations of the staffing models and determine the efficacy of those models in different types of MLP sites. Scroll to the next slide. All right, as mentioned, again, we have a group of faculty. You're hearing from me, Bethany Hamilton, Director of the National Center for Medical Legal Partnership. You've heard from in prior sessions, Keegan Warren, who's the Executive Director of the new Institute for Healthcare Access at Texas A&M University's Health Science Center. And on today's webinar, you'll now hear lead faculty Jay Siklik lead the conversation. Jay Siklik is adjunct professor of law at University of Connecticut, or UConn, but also the former MLP director of one of the nation's original medical legal partnerships in Connecticut. Is a pediatric MLP. It really is one of the first in the country. So we're going to welcome Jay to lead today's conversation. And before we do, let me just recap where we have been. So for those of you who may have missed session 2, I apologize. Let me make sure y'all know how to receive help. Reha, let's go back and scroll to that last slide. As per the usual, but not to be forgotten at all, Reha Manikandasamy is our data scientist on the National Center team and providing us with tech support today. So feel free, if you need some assistance throughout the webinar series, to reach out to Reha using our general inbox. The email address is ncmlp@gwu.edu. You can also direct message her if you need some assistance. Thanks, Reha. Don't want to skip you. So let's do the quick session 2 recap. Let's go to the next slide and the next one. Just a very, very quick brief reminder that on session 2, we started to talk about, and this conversation was led by Keegan Warren, what broader staff do you need to meet the social determinants of health needs that you identified and will be meeting in terms of goals through your medical legal partnership. We discussed the legal interventions that an MLP legal team takes to address social needs. We compared best practices in assessing MLP activities with your current staffing. And then we examined the P, or partnership, aspect of MLP and the roles of the individuals across disciplines in meeting health harming legal needs. That recording from February 15, 2024 is on our website. Again, feel free to direct messages if you need help finding the homepage for the webinar series. Thanks, Reha. Let's go to the next slide. All right, so for today's conversation, I'm going to turn it over to Professor Jay Siklik to talk about how to staff the integrated legal services of an MLP. Jay, all yours.
Thanks, Bethany, and good afternoon, good morning to everybody joining us. As Bethany said, my name is Jay Siklik. I won't go into too many details of my history with Medical Legal Partnership, but Bethany is right on point. I helped start the first, I think, true, and if we want to put it in the terms of today's forum, contracted model, which I'm going to tell you I don't like that term. It's not anybody's fault, but I'll tell you why I don't like it in the about 15 minutes when we get to that part of the program. But that is the contract between two separate entities that form the Medical Legal Partnership that I was fortunate enough to become part of many, many years ago. Now I'm fortunate enough to work with these very talented folks at the National Center and as a part of this grant, and surreptitiously working on potentially another medical legal partnership that hopefully will blossom into something productive and perhaps even successful in the next few months, weeks and months. At any rate, how do you staff the integrated legal services endeavor in a health setting? I want to take you back for a second before we get to the next slide, which will focus on the direct service model. But I want to take you back. You don't have to close your eyes for this exercise. It's not a TED Talk, I promise. But take yourself back a number of years, right? Imagine that it's about 25 years ago, and you have an idea, right? You want to bring something forward as a thinker in terms of working with populations that are most at risk. And you say to yourself, I want to make legal services more accessible, but not for convenience purposes, but for transformative purposes, right? Think of the difference. Convenience is potentially having a branch of a bank in your local supermarket, right? Or having a restaurant that is a chain restaurant in a hospital system, right? They're contracting out to have an à bon pain in the lobby, right? That's the convenience purpose. But say you wanted to do something that was not only convenient, but transformative, right? And so what would you propose if you wanted to do this in a health setting, in a clinical setting, whether it be a health center, an acute care hospital system, any type of clinical setting that you can think of? You could walk in and speak to the administrators in that clinical space and say, I'd love to have a table in the corner of your clinic room. I'm a lawyer. So I would really like to come in and work with your patient population and set up a table on the side. You'd probably last about 5 seconds if you were lucky, maybe 2, because the last thing that a clinical administrator at that time would want to hear is that there's a lawyer who's sitting in our health center who is not working for us. What is the lawyer going to do? What is the lawyer going to accomplish? And good Lord, now there's a lawyer whom we don't employ sitting in our space. How does that work? What is the benefit to us to do that? And how do we think about this in more than a two-dimensional space, right? You have a desk, you have a lawyer, you have a client, and then you have a patient, and they're all confluencing in a way that had not existed before. So if you think about that 25 years ago or more, the logical scenario for that patient population was to refer that individual to a legal services provider. Go see legal aid, go see your legal services provider, go to the law school clinic, whatever it might be, and seek legal assistance in the traditional model, right? The idea that you might be able to access that type of integrated service in a clinical setting was pure fantasy, right? It was pure fantasy until one visionary individual thought about how to do this and was able to pull it off from the inside, not from the outside. So the derivation of the integrated model of partnership actually started on the direct legal services side. And that was, for those of you who are familiar with the history and the background of medical legal partnership, the behavioral pediatrician and director of pediatrics at then Boston University School of Medicine and Boston City Hospital, Barry Zuckerman. And he hired a lawyer. He hired a lawyer, incidentally, unbeknownst to the legal staff at Boston City Hospital. But there are not many folks who could have pulled that off at that point in time other than Dr. Zuckerman. But think about that in the sense of how would you do this if you were building a model from scratch? Would you hire the lawyer to come in and work under the auspices of the umbrella of your health center organization? Or would you seek out partners in the community for reasons which may be potentially very probative and important, but difficult because you don't have the relationship with those folks? So how do you proceed ahead when you're starting from scratch? And I have to say, I'm really encouraged by the poll results because I was not expecting the number of folks to come in with perhaps such a spread of potential setups, and I think it'll be fruitful for discussion. But so take yourself back, think about how you would do this from scratch, and not by using past present information as a prologue to figuring out how to do it then, but think about how you would do it if you had never done this before. What would you choose? Why would you choose it? What would be the strengths and weaknesses? And that's where we're going to go today. So we started in the 90s and then in 2000 with the idea that maybe there was another way to effectively provide a partnership with an actual partnership between an external and an internal scenario where two entities decided to have that courting and have that relationship and start a partnership. But the question is are there advantages to one particular mode, or is there advantages and potential disadvantages and liabilities in both scenarios? And that's what we're going to talk about going forward. And again, as Bethany said, we're going to invite as much active participation as possible. And we're going to start, if you'd be kind enough to go to the advance the next slide, Reha. We're going to start with the direct service model. So as the name implies, this is the health center, the medical entity, deciding to build a structure internally, right? How do we assist the existing patient base, the patient population that we have, with legal assistance to handle, as the term implies, the health harming legal needs that are expressed in almost every single scenario when we deal with our patient population. Okay. And again, as the model implies, everyone in the partnership is part of the health center or the health entities under their umbrella. They're employing the clinicians, they're employing the social workers, they're employing the frontline staff who meet the patient base, and the lawyers and the legal staff, if there are such folks, who will be providing that integrated model of care. Okay. It is less frequent, and Bethany and I had a chance to talk about this. The data is pretty stark that the great majority of partnerships are the second model, the contracted model, if you will. But there are obviously entities that have adopted the direct service model. And I think it's a good opportunity to talk about, especially for those of you who are mulling over, how do we take the first step? Where do we go when we want to begin this integrative process? What does each model look like? How is it a play, if you will, to bring everyone under the same roof and to integrate everyone into the same system? There's a database, there's communications, there's the same systems, the same technology, and you're in the same space. You're literally in the same space, potentially right next door to the room where it happens, as the saying goes. Okay. So let's go to the next slide, and this will be a good opportunity for folks in the audience to provide us with some of your thoughts. And let's go to that if you'd be so kind. Thank you. What we've done is we pre-filled this, but then we were mean and we took them out. So we're not going to show you what we think, but we want to hear what you think about what are the benefits and challenges, and consideration is a little amorphous, but they can really fit into any category aside from if it crosses over from benefits and challenges. But what, for those of you, who may be particularly involved in the direct service model, tell us what some of the benefits are to start, and then we'll move on to challenges and considerations. And we have our first contestant. So Haley, please give us your thoughts and tell us what you'd like to add in terms of if you're going to talk about the benefits of the model.
Yeah. Hi, I'm Haley Greenwell. I'm a social worker with Memphis Child. We're the medical legal partnership of Le Bonheur Children's Hospital here in Memphis, Tennessee. And we do have one attorney on staff here at Le Bonheur Children's Hospital. And the benefit of it is that, just as you said, it's clear and precise communication, data collection. We can track all the events of the worker, and we get feedback like real time. He's also able to help present our program when we do roadshows to the hospital and answer any legal questions that may come up during that time. Can I also say a challenge?
Yeah, you might as well. I mean,
Yeah.
certainly, let's go through whatever's, you feel is important. But yes, absolutely.
Yeah. So we're currently trying to expand our medical legal partnership, and it has been a challenge to replicate what we have with my supervisor, who is the attorney on staff. And that's mostly due to salary and pay range within the hospital. They continue to say that, like, my supervisor is an exception to the rule. He is paid half through the hospitals and half through grants, and that's made it really effective for us. But it's been hard for us to replicate that model with anyone else. He has a special relationship with the hospital because his daughter was a patient, and he's a huge advocate of our hospital. But yeah, just getting another attorney has definitely been a challenge.
That's great, Haley. Thank you. Do you mind if I ask a very quick question?
Yeah.
Is the attorney who is dedicated to your medical legal partnership a full-time medical legal partnership attorney, or does that person have additional responsibilities or other things?
No, yeah, he is a full-time staff attorney. He's actually our senior attorney with our medical legal partnership. And I believe the title is just due to his years of experience and his pay range. But yeah, we're on staff. We're here Monday to Friday, 8 to 5.
That's terrific. And you are part of that MLP and additional
Yes.
responsibilities as well in the health entity?
Yes, so we're a collaboration between four entities: the local medical school, the local law school, the local legal aid group, and then the local children's hospital. So myself, as well as my supervisor, Tim, the senior attorney, and our intake coordinator, which we just hired, we're all through the Le Bonheur leg. So we're supported through grant funding with the exception of my supervisor, who's half grant and half Le Bonheur. But the rest of us are paid primarily through grants, but we are considered Le Bonheur employees, meaning we are on staff with the hospital. And I wish we had more attorneys on staff. So that's the reason I'm really excited for this webinar today. Thank you for your questions.
Yeah, thank you well, you're welcome, but thank you for that. I think that is a wish that is universal, that we wish we had more lawyers on staff. I
Yes.
think that is the, $60,000 question about from both sides of the equation. How can we do this better? Which doesn't always mean bigger, but it sure doesn't hurt to be a little bit bigger in that capacity. Thank you very much for that. Anyone else with any comments or thoughts about benefits or challenges, either actualized or theoretical, that you can think of?
Nothing else has come in yet, Jay, but I'll
Okay.
keep an eye on the chat as well in case folks are more inclined to share via chat.
Absolutely. And again, if anyone in the process of us going through this has anything to add, please throw it in the chat, or feel free to hop on board and oh, okay. So we do
Okay,
have someone. Yep.
Yes, we have Stacy. Stacy, would you like to go ahead and unmute your microphone?
Yes. We have, so I am the director of behavioral health, and I actually, the MLP reports up to me, which is pretty unusual, but I inherited it a couple years ago. I work for a federally qualified healthcare center where our staffing is, we have a community health worker that is employed by the FQHC, and then our attorney is employed by our legal aid. So they are contracted. Both of their positions are grant funded. For us, it has been beneficial for having the contracted purpose, for that my attorney has additional folks to case consult with. If she was on her own, other than just meeting with folks in her sector, she wouldn't have that case consult. So that has been beneficial. What has been a challenge for us is that because she is employed by the legal aid and not by the health center, there's challenges in between sites, where she's going, the time that she has allotted for between where she has to be at the local legal aid versus being at the health center. And then also it only gives us room for one person, one attorney. And so she, at this point, only really does intakes, and then everything gets pushed off to the remaining attorneys at legal aid. So she only gets to do the initial conversation, and then, but then that person still comes back to our health center. And so it kind of creates this area of kind of confusion and disjointedness for our patients at the health center.
Thank you, Stacy. When we get to the contracted model, I think you have articulated a very common issue that comes up when there's not someone there in the building, in the space, almost all the time, right? That is one of the, I think, primary challenges in the partnership model from a contracted point of view. And I think we'll get to that when we get to some of the significant challenges, because even though there may be more benefits that outweigh challenges in that model, you bring up an extraordinarily important point. Where is the person? Where have they gone? When are they coming back? How do we get feedback? When is the next time that person's going to be here? So that's why different models within the models can actually have a range of efficacy or be challenging, even within the idea that, hey, I think we've got this thing pretty well designed and it'll operate like a well-oiled machine, when, as you can see, there could be issues even with the best of intentions. So that's excellent. Were there any more challenges or benefits from the direct service? Because I'll go to the big reveal, because I saw you
Yeah.
write a couple of things in the chat, Bethany, but I wasn't able to
I
catch it.
think they're going to come up in the big reveal. So I'll just quickly mention a couple of things that came in the chat. Keegan's also in the chat engaging from Callie Q. This comment mentioned the lack of restrictions on who can be served can be a challenge. And we also had a benefit shared of the direct services model, or excuse me, a question about just clarifying the benefit of the direct services model. So we'll get to that on the next slide, where we display what we have identified as benefits. One of the other challenges noted just very quickly in the chat is confidentiality and conflict of interest. So maybe we should go to the next slide and have that deeper discussion about what we've identified with regard to the direct services model.
I agree. Excellent point.
And Jay, do you want Reha to go ahead and scroll to?
Yes, I'm sorry.
Okay,
Yes, if you
thanks.
wouldn't mind.
Thanks. Reha, go ahead and scroll to the next slide. Thank you.
All right. There's a lot on this slide, so I'm not going to read every little arrow. Even I got a little bit excited about adding more arrows. Once I figured out how to lower the font, then it was game on for me. But let's talk a little bit about some of the things that were already mentioned, and I'm going to highlight them rather than, again, kind of go through every single one of the bullet points. The things we've talked about, the direct service model, that are pretty self-evident, we've mentioned already. It's the idea that everyone is integrated in the same space, right? Everyone is under the same roof. It's a lot about potentially control and the idea of availability. And I think, you know, as we've already talked a little bit about, the idea of having someone in the building, in the room almost all the time, provides that necessary symbiosis, if you will, that integration that is available right off the top. Again, assuming that the direct service model provides enough funding and enough availability for an attorney or more to be full-time. The same can exist in the contracted model as well, depending on the relationship between the two partners. We'll certainly get to that. But the last point is one I want to really emphasize in terms of the benefits here. It's the collaboration on the workflow and patient care without, and I put this in italics, apparent conflicting interests, right? Everyone is on the same page. The lawyer is immediately part of the system, and everyone is part of the culture of the health center, of the healthcare entity, if you will. There's no ulterior motives. What are the legal services folks thinking? What are their agenda? For example, we're all here, we're all formulating those same metrics. We're all formulating the same goals. We're formulating the same outcomes. We've done the needs assessment together, and we know what our population base is most in need of, and the lawyer is going to be part of that team from day one. So that is, again, a summary of the benefits. We've talked about them a little bit. I want to talk about the challenges for a couple more seconds. And again, I invite, you know, certainly Keegan and Bethany to jump in at any time, or anyone else if you have any comments. But there is a lot of weight on the shoulder of an individual lawyer who is basically operating a law office of one. Think about the significance of walking into a building. You're not part of a law firm. You're part of a different institutional setting. And a healthcare setting, even though it may have the same goals and outcomes in the MLP, has vastly different goals and vastly different objectives in terms of its organizational structure. There might be a lawyer on board if the health center employs one or more, if it's a system, but those lawyers are not looking at the same goals, metrics, outcomes, and objectives as the MLP. So it's very difficult to find someone who is able to and committed to building a legal department if you're one person. It's a big load, it's a big carry. So I want to make sure folks are aware of that. I think as we've already talked about, Haley particularly, capacity expansion and building to scale is really hard because, again, you're going to be pretty busy from day one, assuming you have a plan. There's a workforce a development program that you're trying to get a good line on what the needs are and what your focus is on. But you're going to get legal issues coming from every direction, from north, south, and every other direction. So who's going to handle those brief information issues? Is the lawyer capable of providing brief information and a quick consult? Or will the lawyer have a team of folks in an external organization that can help them out? And then I think the one of the most significant challenges is, and I think I saw it in the chat, and Bethany, you certainly wrote that, was this idea of conflict of interest. I wrote in the idea of having someone on board that you can kind of marshal all the individuals together, and conflicts may not be as significant as you would think. You have one entity, everyone's employed by the same organization. But those of us who are steeped a bit in legal ethics, and those of us who actually teach it at the law school level, start to look at red flags almost immediately, because the confidentiality and the patient-based confidentiality of HIPAA and other statutory provisions is very different than the ethical responsibilities that lawyers operate under. And I am not going to bring out the rules of professional conduct today. I promise I won't do that. But the golden rule is rule 1.6. Okay, I did it. I'm sorry. But for those of you who are lawyers, this is the critical rule that is the basis of the lawyer-client relationship. Where does that fit in when you're sitting in a team meeting and you are sharing information with other individuals who are employed by the same entity? Are you under the same responsibilities, and are you provided with some out or exit strategy when you have confidential information? The expectations may be very different than if you work for a law firm, meaning an outside legal organization. So again, without getting into too many of the specifics of the challenges, just be aware that there are significant issues in terms of confidential information sharing, even within the boundaries if everyone is employed in the same space by the same entity. So there are a number of fairly good articles that have been written already in this area, and we can certainly share those with you because this has been an issue from the very start in medical legal partnership. So just keep that in mind. Yeah, go ahead, Keegan, by all means.
No, I just wondered if I could jump in for a moment, because there's a theme that I'm hearing here in both the excellent comments from Haley and from Stacy, the comments in the chat from Callie, et cetera, and then what you're saying. It sounds like there's a real need to make sure that we're clear about what the work is, how we define it, what our ethical boundaries are and professional responsibility, right? And that if we're going to do integrated services, we need to be deliberate about what that looks like. Is that kind of an accurate summary? So it sounds like even with some of the direct services models, that some of the challenges are maybe caused by not being express about what integration looks like.
I think that's an excellent point. I think that, and I think it works on both models. I think that there has to be real specific guidelines about what integration looks like. is your model going to be a fully integrated model where everybody is sharing information, including electronic health record access? And, how does that work in either model? Is it going to be more of a, you have a opportunity to see someone who's been referred, but that integration exists in a very different space? So I do think that that's really important. And I think, there are many different ways of looking at integration. And, certainly I'd love to hear of other folks and what they think about this. But in our medical legal partnerships for the years that we ran several different spaces, we really strive to have full integration as much as possible, even though we were two entities that were contracting, if you will, from outside entities and weren't part of the same system. And that was very difficult to overcome at first. And having provided some technical assistance over the years and spoken to general counsel, for example, for healthcare systems, that scares the heck out of them, because full integration is not something you do when they're dealing with all kinds of vendors and all kinds of folks who are providing technical assistance on medical equipment and research and all kinds of other things. So it really opens up a Pandora's box potentially for some of the significant issues that we touched upon in terms of confidentiality, information sharing, both ways, by the way. And, who gets to contact what and who gets to advise the clinical staff, for example, when there are questions of ethical, medical, and legal responsibilities. And it becomes a really complicated web, so to speak. And I guess the ability to think about those and plan as much as you can't plan for everything, is critically important. Finally, just want to talk a little bit about some of the considerations. The idea here is there are, and I wrote down a little bit of a laundry list. They're in the considerations, but think about, again, some of the things we've talked about. The knowledge base of the attorney or the staff that's going to be faced with a myriad of legal problems. Even if you highlight and specifically narrow the focus of what kind of health harming legal need you're going to be focusing on, you're still going to have to field a lot of questions about things that fall outside that realm. Number two, sustainability, right? The sustainability factor, and again, I think I saw Keegan write about budgeting and sustainability, that's going to be at a future date. Is a really important question because, again, priorities, funding mechanisms, and sources for health center entities are far different than for legal services entities, right? And each one has their challenges, mind you. There's no pot of gold at the end of the rainbow if you choose the contracted model, but priorities shift, priorities change. And if you look at the mission of a health center, the mission of a health center is to serve a population from a health perspective. And even though we will preach to you that we are part of that health model as medical legal partnerships, that is not always the view that may survive the chopping block at the end of the budget cycle. So you have to really be considerate of that. And then, as I talked about, some of the ethical issues that are going to present themselves. For example, the idea that you may have learned information as a lawyer that you do not feel comfortable sharing, but that may very significantly impact a plan for a particular patient. Especially, I think, as Stacy might be familiar with, in some of the behavioral health issues. These are really acutely important, especially those of you who are dealing with younger individuals and youth at risk. The behavioral health plans and the confidentiality of information provided to a lawyer may be vastly different than the information that the team might have that is doing some of the planning, whether that be in an ambulatory setting or in an inpatient setting in an acute care hospital. Again, you can see that, we're talking about the model that is used far less frequently, but yet it brings up a significant amount of issues and thoughtful discussion that I'm sure a lot of you have already pondered. Okay, let's move to the next slide. before I spend the rest of our time on direct service. Oh, here is another one. How about that? This is really a summary slide, so I'm not going to go over it for very long. I want to highlight a couple quick things on this. First, the highlighted portion in bold about a manager level lawyer. That may be somewhat self-evident after we've talked about this, right? There are a lot of legal service programs that employ fellows, for example, that are just starting out to start up a medical legal partnership. But think of the background and the support that a fellow might have, or a lawyer who may be a year or two out of law school. There's usually an entire infrastructure behind that individual to support their work, right? But that's not going to be the case. You're not going to have the independent, poverty-based or health equity-based law firm behind you. You're going to have to be all the things and more in the column on the right. The self-starter, the generalist, and the specific expert know about the issues that affect patients that are specific to that health center entity. That work with individuals who come from backgrounds that may be very similar to the type of client base that legal services programs have. But if this lawyer has not worked in that environment, then that may be very different. Individuals with trauma and some of the more significant issues that a health center population may have on a daily basis. And you really do have to think about someone who has specific expertise in the moment on a particular issue, because if you try to play the generalist at all times, I think you'll probably have a very significant potential for burnout if you're not dealing in a focused area. But then again, on the flip side, what about all the referrals that you get from your colleagues who want help on issues B, C, D, and E when you're focusing on A? So these are all considerations to put in the back and think about. Okay, let's move to the next slide, which is the integrated contracted model. Okay, and this is again the more common model where there is an agreement, a contract, if you will, a partnership between an outside entity and the health center or the health entity. Okay, lawyers work for the lawyers work for the legal services entity, the legal aid entity, or the law school pro bono, whatever it might be. And they are really forming that integrated partnership to achieve what I call a symbiotic goal, right? That's what the idea here is. You bring in sometimes two folks who've really never met or worked with each other, and two entities that really don't have a lot of cross association except for potentially referrals, right? Oh, you need to go see the legal services provider in your area. They handle all these types of cases. Or, oh, you really need to get to the health center because we're working on a disability case and you really need an evaluation to determine the extent to which you have all the different factors that might play into the disability scenario, as an example. I don't love the word contracted because it sounds antiseptic, right? Or flavorless, right? And especially for those lawyers in the house, unless you're really some savant of contracts, it's probably not the thing you carry with you from law school with the greatest of memories. Boy, I can't believe I really haven't talked about offer, acceptance, and consideration in the last few weeks, right? I think, however, it is the best way to classify it if you think more, and how should I say this, a little bit more out of the box about what this is. The contract it with a partnership or contracting, two like-minded entities together. That's what you're doing. You're bringing together two entities and taking the best of each with some considerations from each particular entity. Yes. Those of us who are remembering contracts, I try not to remember that for specific reasons, Bethany, which I'll share at some other time, but not during this webinar. All right, let's go to the video, as they say, on TV, and see what folks believe are the advantages. And we've talked a lot about this already, so I don't want to spend too much time on this, but let's talk a little bit about advantages or limitations, as you can see, and perhaps those of you who are already in the thick of it can share some of the things you've already talked about. And feel free to raise your hand or unmute or throw things in the chat.
If Callie, if you want to go ahead and unmute, you should be able to speak.
Yeah, can you all hear me?
Yes, thank you.
Okay. So I'm biased. I work in a hospital where we have the hybrid model. We have both a direct, I actually supervise a team of 4 attorneys, and then we also have a contract with legal aid. I was the sole attorney at one point, and a lot of those disadvantages that you said about that I could resonate with. But I also think there's advantages. But specifically with the contract model, legal aid organizations have the knowledge, they have the contacts, they have the ability to do systemic litigation, all of those things that really make a medical legal partnership robust. I mean, we do a lot of individual casework in our medical legal partnership, but without legal aid, we couldn't do tackle some of those bigger systemic issues. On the downside, one of the reasons that in terms of limitations of just a contract model, one of the reasons why I pushed and our hospital determined that we must have in-staff attorneys or in hospital employed attorneys were the limitations of our legal aid organization in terms of specifically, health equity, specifically around their service of undocumented immigrants. We did not feel comfortable having a program that could not serve a population of people. And so having those hospital employed attorneys allow us to eliminate any restrictions to service.
Excellent. Thank you for sharing that. And again, I think you've also raised a really interesting point that I think we're going to talk a little bit about it sounds like you have kind of a tour de force staff. If you have 4 folks working internally and you have that contract relationship with the legal services provider, that's a pretty robust MLP. And that sounds like, and again, having worked in one that decided that those systemic health equity issues needed to be addressed both from the legal and the policy side, that's very ambitious but extraordinarily rewarding. And I think that having potentially that hybrid model really gives you that ability to be on both sides of the fence, right? You can handle the day-to-day matters and work on some of the more specific systemic issues that arise because of that interaction in the day-to-day space. So thank you for sharing that. Anybody else? Bethany?
In the chat, I just want to call out a couple of comments that came in from Wendy Asher that were some really astute observations. So Wendy is sharing that the confidentiality issue is one argument for the contract model. We only confirm that we have contacted the patient or client and only provide additional information with the consent of the person who's now the client. So the contract model has that advantage. Another advantage that Wendy mentioned of the contract model is that as a legal provider, they bring all of the firm's resources rather than the limitations of skill or time that an individual attorney might have. So let me just double check. I want to thank Wendy for sharing some of those comments. That's it for comments, but I just want to encourage folks to feel free to raise hand or continue to comment, and we'll keep our eyes on the chat. That's it, Jay.
All right, thanks, Bethany. I appreciate that. Reha, if you don't mind doing the big reveal for the next slide, we're going to fill in some of the things that I know will overlap over some of the stuff that Callie, you said, and that we had talked about before. And I know Stacy had brought up some of the points in her comments previously. Again, I mean, we've talked about some of these, but I do want to highlight them. And I've put in a couple of things that again, we've talked about, but I want to elaborate a little bit more on. So, what you just talked about in terms of your recitation in the chat, Bethany, the experience and the depth of knowledge, right? Even if you have 1 or 2 folks in the health center that is a employee you still, unless you have that very special relationship or have a direct line into your local legal service providers, it's still not the same as having those folks as colleagues and having that instantaneous ability perhaps to get a consult or dig a little bit deeper into an issue, right? You have the opportunity for folks who've spent a number of years in these systems at legal services or legal aid or at other directed nonprofit legal advocacy centers who bring a wealth of expertise and knowledge. And then again, I'm going to go back to this conflicts of interest issue. I think the boundaries are pretty well set. They can be certainly crossed with appropriate communication. But there does appear to be this ability to kind of have that wall of independence when you are dealing with these sensitive issues, and you have the opportunity perhaps to make some judgments based on other individuals in the organization who have expertise in legal ethics, conflicts of interest, or crossover into medical or bioethics issues that from the legal side. So don't discount that. As we said, and I think as you just brought up, Callie, there are limitations of some of the work that legal services organizations can do on the policy side, on the litigation side, on the substance matter side in terms of immigration, in terms of reproductive health, in terms of lobbying, in terms of legislative stuff, in terms of advocating for reproductive health issues such as abortion, et cetera, et cetera. I mean, these are really important things to know and to go in eyes wide open. And so some legal service organizations, because of restrictions that have been set down either locally or nationally, do have certain restrictions regarding the substance matter of legal areas that can be worked on. So that's certainly something to consider. It's not often that outside legal entities are contracting with health centers, except in the traditional fashion. We need a law firm, we need to pay lawyers to do contractual work or to do regulatory work or whatever it might be, employment-related law. This is a very different avenue, and it's a very different scenario where you're usually not in your comfort zone when you're dealing with a legal services entity. Health centers may be more comfortable with law firms or other type legal entities that provide that guidance, but not necessarily a legal service entity. And legal service entities, for all their strengths, and I know because even before I worked as a medical legal partnership guy, I was a legal aid lawyer for 6 years in a very large legal aid organization. So these are not the kind of areas and priorities, dynamics, funding that is typical in legal aid. Legal aid has a very specific structure, but the good news is that most of you who are on this call and who are working in medical legal partnerships work for organizations that have the foresight and the ability to kind of stretch the envelope of traditional legal service models. But just be aware that some legal service organizations just do not have that understanding of the relationships and the goals as well as the mission of health center work. Next slide, please. So I'm going to talk a little bit about the process of starting this particular endeavor. The idea here is that there's a number of different scenarios that you should take into account when dealing with how does this process work. The point I want to make, and again, you can read the bullet points certainly as well as I, there is a lot about each other that health centers and legal service entities don't know. And there has to be a lot of communication and a lot of understanding. That may not always be the case, but some of you may have expertise and are leading the charge, and maybe folks in the health center have done a lot of research and a lot of work, and so do understand that. But I want to say about the process of getting together and kind of forming that relationship, if you will. and this is a point that I take personally because it affected the first few years, and I'm not overstating this, that there needs to be a pretty long honeymoon period, if you will, of acclimation, gathering each other's knowledge, and understanding culture adaptation. Okay. You may think you know how things work in the other organizations, but taken from someone who thought he knew what was the culture of a hospital, you learn very quickly there's a lot more you don't know than you do. I think with the right mentorship and the right leadership, for example, on the health center side, that can become a shorter honeymoon period, but keep it in mind. There are a number of things that you need to learn, and the mindset of dealing with a population base of patients is very different than clients. And once you get into that integrated model where it becomes one individual who's being seen, represented, and provided to by the team, then it becomes a very different mindset. So just keep that in mind. Health centers finding a partner, I'm sure you're well aware of the different entities, the traditional legal aid or legal service model, law school clinics, which serve a smaller number of individuals, but may be more specified in the type of work that they do. We have an immigration clinic at our law school. We have a housing clinic. We have a intimate partner violence clinic that seeks to work with individuals who are victims of violence. We work on issues that are specific to disability rights, civil rights, you name it, but you're often very much likely to find a more zeroed in type of specific legal service model in a law school than you would in the general legal services entity. And finally, there are pro bono legal services entities. These are entities that provide law advocacy without charge and come from potentially larger firms that gather lawyers who would like to volunteer their time, et cetera, et cetera. But the part of all this that I think you have to think about is, what would you like to do, right? What is your focus? Where would you like to spend your time integrating the expertise of the lawyers and the health professionals in this particular entity? Basically, what do you want to work on? And that is really the first step in not only thinking about the process, but also finding a partner.
Hey, can I make another observation?
By all means.
It sounds to me like, and part of what I'm hearing here is that even with the contract model, health centers need to think of this as an onboarding process, right? When you bring on a new employee, you don't assume that they know your organizational culture, and that this contractual relationship doesn't mean that organizations should expect to get to be at arm's length and not learn each other's culture. If at least they mean to have an integrated approach.
Yeah, absolutely. Absolutely. It really is, again, it's part of the idea of learning, and as my old boss used to say, knowing what you don't know, starting to realize that you don't know a lot, but getting to the idea of learning. Next slide, please. And Haley, I'm gonna answer your question in one sec, as I think I glanced at it. But Reha, if you could just move it to the next slide.
Let me see if Reha is having any technical
there we
There
go.
we go.
Okay.
Rocking and rolling again. Thanks.
So Haley, when I directed that medical legal partnership, it was not directly affiliated with a law school clinic. It was affiliated with a law school, but not directly as a clinic per se. That is kind of what I'm working on now to kind of re-engage. But again, they're very different models, very different entities. But no, I did not work in that. And then it becomes, now you have a third party involved, right? You got a law school, you have a clinic, you have a health entity, so it's a it's a little bit of a different environment. Okay. So there are 5 questions. These are the 5 questions that we've developed to think about for evaluating the community-based organizations. The first is organizational capacity. Who's coming into our organization, right? How many of you are going to be in our health center? How much are we going to have to fork over, or what is this going to cost us, either in actual dollars or in-kind support? Do you need an office? Do you think that that is a small question? That it can be a killer, because and I know this from experience, the best of intentions can promise the moon, but when you get down to it, that office may have now been converted from the time you sign your agreement to the time you walk into the health center into a very significantly needed clinical space. Or there's a number of folks who have come back into the health center that need that space. Who's going to be there to help the lawyers, because we're not going to be able to help them? And who's going to do the data collection for the legal side? Are we going to be responsible for that? Is that the legal services entity's responsibilities? So these are all important questions to think about in terms of the organizational capacity for the legal services entity. Are you bringing in ad staff? Is there a paralegal who's going to be here? Are you going to be working remotely? Are you going to be directly involved? So these are all really important questions. The second one, which I think is directly related, if not kind of integrated with number one, is how many hours? Who's going to be here and how much? I think what we heard before was some of the concerns of the contract model, if you will, is that, well, there's somebody here for a few hours a day, but then what? Is this going to be an embedded individual who's going to be here all the time during our business hours? Are they going to have fixed days? Are they going to have certain intake? Is it going to be fixed or walk-in? And how does that work for the admin staff of the health center that's already fielding all the folks who are coming in on the health center side? Again, we like to think of all this as an integrated system where everyone's coming in to see the professionals who can provide this advocacy. And I mean that in the very, very largest sense, but that's not always the case, because sometimes the health issues are really health issues and they're very acute. And so who's going to see the staffing for the walk-in hours, for example? This is really important to think about. And again, for those who are in remote areas, in terms of rural areas or technology kind of limited, what's the technology going to look like? Is it going to be, as the health system has evolved through COVID, is it going to be more virtual type interactions? Does that lend itself well to the type of practice that the health center is providing? And how is that going to be done? Who's going to provide that technology? And in what system is the legal staff going to work in regarding scheduling and then effectively providing that direct service? Next slide, please. Okay, so personal assessment, really important. And you can read the bullet points about the type of individual or individuals who I think are best suited to the integrated model. And again, I think this is not unique, by the way, to the contracted model. It's really, I think, identical if the health entity is going to hire its own staff. These are really important. How are you at understanding these important issues that are very unique potentially to health center patients? What do you know about health equity? What do you know about health-related issues? Just the basics, I think, are really important. You don't have to bring home the Grey's Anatomy and start learning about the specifics of diagnoses, but you should know a little bit about what's going on, because you're going to be working with populations that have those health-harming legal needs, and you need to know how to address them directly to the medical folks when you're having those conversations. Yes, you're going to ask questions about the complicated stuff, but it really helps to have that knowledge, just as you would about the type of legal interventions if you're dealing with evictions or if you're dealing with immigration issues, et cetera, et cetera. And I want to point out the last highlighted point on the personal assessment side. You really need to be humble and willing to learn. And what I mean by that is we're willing to relearn is that, again, you know, a little knowledge can be a dangerous thing if you walk into an entity where you may be very familiar with the legal systems that these individual patients are confronted, but you may not understand how that integrates with the trust and the relationship that they have with the medical providers. And that's a really important point because, again, you know, certainly working in a child and young adult related atmosphere, the touch points of an individual family's lives are the school-based folks, the family and community connections that these individuals have made, and the health providers, right? Think about that. They're really one of the triangle of the three most important points. And the health center providers may have a much more significant relationship, at least at the start, than you would. And I think that's really important to remember. Humility about knowing the things that the individuals, and they may be hesitant to share some of that with you just because they have that relationship with providers, and you building the relationship with, or you as the legal folks building the relationship with the health providers is so critically important on a personal level. And again, how you do that is as varied as the personalities involved. But getting them to understand what the point of this is and having that interpersonal relationship, even if it means spending a lot of time just talking, sitting, listening, and learning, is so important. Hence the bidirectional trainings, or sitting in on meetings that you might not have a lot of involvement with, but just to be a good listener and a learner. That's what people appreciate. Okay. And then the knowledge of intersection between health and law, right? Again, this is a pretty self-evident. So what are the issues that you're trying to understand and to measure, right? Are they social determinants that impact health equity? Do you have a partner that is very acutely aware and involved in active health equity, health justice type practice? Does it just go for the numbers, or does it go for the underlying issues that I think some of you have already talked about? Some of those systemic issues. Why is this population in this particular segment or quadrant of the city being evicted more? But why are they also showing up in the emergency department more? Trying to link some of those significant issues. Why do they have a higher incidence or rates of asthma or COPD, for example? Is there something that is not being addressed on both sides of the equation, right? How are you handling some of the individuals who come in without legal status, right? The health center's mission is to see them, but what are we doing in terms of trying to figure out, is there a pathway so that we can work together collaboratively? Are you aware of how the health center deals with individuals who may have underinsurance or may not be eligible because of that immigration status? So these are all things to think about: the knowledge and intersection, that ability to share and the ability to provide that on a regular basis. The last point here is think about what the mission of the health center is and what your greatest need is. Yes, the generalized legal services and legal aid programs are the benchmark and the foundation of civil legal services, but there are specialty legal services organizations as well. Does your health center have a higher impact of veterans in your community that are being seen, for example, on off times as opposed to the VA, right? Do you have walk-ins or connections with families? Do you see a lot of issues in the child welfare system that are impacting your population base? Juvenile justice connected issues that may overrelate. or some issues again regarding a heavy population of immigrants, whether they're here with status or they're here without legal status, and what are the benchmarks of their outcomes and what legal needs are not being met as a result of that interaction. Okay. Next slide, please, Reha, if you would. Thank you. And again, this is, I think, an overlap of what I just talked about. But I think one of the things that hits, and again, those of you who are coming from the health center side, please feel free to jump on or put something in the chat. But perhaps hits something pretty quickly is the phrase, "I don't know the answer to that question," from the lawyer, right? Boy, I thought I knew a lot about this particular area of law, but you've just opened up a new tangential, but albeit really important aspect of this particular patient's care, but also the legal recourse that they may possess in a particular area, right? Is the legal services organization willing to go a little bit outside of its comfort zone, as I wrote there, in an interdisciplinary setting, right? The crux of medical legal partnership is that it's in fact interdisciplinary. Within health centers, I'm sure most of you have already recognized, social work and kind of direct clinical activity. That's interdisciplinary in its own way, but it's always been a straight pathway that both kind of entities kind of go towards the same goal. But it's not always been understood that the lawyer, the legal services entity, is also trying to figure out that pathway towards better health outcomes, right? What are the causes of those poor health outcomes? Are there things we can call from a lot of the work that you folks are doing on the health center side, whether it's with community health workers or whether it's a opportunity to engage with other individuals in, for example, a co-located behavioral health clinician who's working on some of these comorbidities that the legal provider may be very, very relevant to, in terms of, well, you know what, we've just discovered that, this particular individual has been doing pretty well from our health side, but behavioral health wise, this is a real difficult case that we've presented. And by the way, there's school issues here. And do you have any expertise in school advocacy? So again, think about this as you're trying to define and identify the expertise of this particular endeavor that you would like to do going forward. Okay, those are the big 5 questions that we developed. I think the next slide goes right to the, if I'm not mistaken, goes right to some of the data and some of the information that that Bethany is going to take over with. And certainly please continue to provide your questions, or we'll certainly open that up, and I'll let you take over from here, Bethany.
Thanks so much, Jay, and thank you, Keegan, and thank you to everyone who participated during the main portion of the lecture, if you will. So I just want to note something about the next few slides. This is a table that is in our Health Center MLP toolkit. We're actually going to hold on to this information because it is going to become pertinent and very helpful and informative to the next discussion on budgeting and funding, where we talk about the different types of legal services organizations, what the landscape is like, and the types of funding that they typically use to support their services, and then how that funding often dictates the types of priorities that they can or cannot set with regard to who they can serve or the types of cases that they can work on. So I'm gonna ask Reha to actually scroll forward so that we can actually get to the Q&A, because I really want to reserve the remaining portion of the webinar time for those of you who are in the participant group in the audience to actually have more time to ask questions of Jay and Keegan. And I promise we'll bring this section of slides with the table on different types of community-based legal organizations back in the very next conversation, the very next webinar, I believe, on funding and budgeting. Okay, that's the Q&A slide, Reha, and I'm going to ask for folks in the audience, if you wouldn't mind unmuting your microphone, raise your hand if you have a question, or feel free to submit a question right now using the chat or the Q&A function. I can help tee up a question here that I noted as a tip in the chat. I'm going to pose this to Jay and Keegan. Some of what was shared were some key questions that folks will really need to address as they decide which model works best for them, whether it's direct services or contracted. And we brought them up. Jay, you presented them on the contracted model in particular. But as we continue to walk through this webinar series, I know we're going to begin to talk about the agreements or memorandum of understanding that MLPs often put in place. Have you seen these sorts of key questions become particularly helpful in the agreements that are, written up between partners, so that you have some key understandings that you can always refer back to? And feel free, I don't know who wants to take a stab at that, what you've seen, how you've seen this inform actual agreements.
I definitely have. I'll jump in here. I definitely have seen this as part of the MOU. I think these are the critical conversations to have before you get started. But sometimes you don't know what the questions are, the right questions are, until you get started. And I think it's fine to use that as an opportunity to revisit the MOU, to rethink through questions of, oh wow, we thought we could handle this through more of a referral network, but it turns out that both sides want more information, and how do we work together to create a document that allows us to be consistent with our rules of professional responsibility, with our rules of ethics, consistent with the law, but also achieve our joint ends. I think that's absolutely the opportunity, and I would encourage not just evergreen commitments, but ones that also facilitate revisiting these questions and the answers from time to time.
Yeah, I mean, I really do think, and again, not to defer to the MOU session, but we're teasing that a little bit, but it's a really interesting and complex question too, because you really do want to think about what you want to get out of the agreement, in terms of, not because someday you're going to use the contract as a opportunity to figure out all the things that you didn't provide, but it does really set out I think that not only the guidelines, but a lot of the logistics of how is this going to work. And when I talked about the office thing, I'm really serious about that. And one of the things we made it an absolute priority in all the MOUs we ever designed. And by the way, it was it wasn't really a arm's length agreement. When we were signing MOUs with these hospital systems, we pretty much took whatever we could get. And when we tried to, and we'd slip in a line or two that was advantageous to us. And I'm talking a lot about liability and indemnification clauses and stuff I really didn't understand very much, but I think I did, because for reasons which we can get into later. But the things we really assured were in there were things like, our folks need actual space. And again, so this is a long time ago, but they need a phone. Again, not quite as much anymore for obvious reasons. They need access to X, Y, and Z, but they need internal support from the organization as much as the organization needs to know what's the commitment of the legal services provider or legal entity. You know, is this going to be an 8-hour, a 16, a 40-hour? Are you going to provide me with an office? Are you going to provide me with confidential space, which is critically important? But because again, they're like, well, you're in with the, you're in with the patient and there's people walking in and out, but it's all confidential, right? Because it's protected by HIPAA. And again, when you're dealing with, very different definitions of confidentiality, those things are really important. And I'm not saying you're going to get a suite in the executive space, with the beautiful conference room that might be available. And again, I know we're talking about health centers here, some for the most part, but you take what you can get. But these are all things that you really have to think about. And I think part of the, really important work that the National Center has done in terms of some of the toolkit information is, these are really good checklists of things that you want to consider when you're going to get into those negotiations. And again, the best thing that can happen is that the folks at the health center who do the legal and the risk type assessment understand the nature of the partnership and the integration, and then it becomes a much smoother pathway, right? If it's a huge organization and you're dealing with a person in a different, location who's in charge of a ton of different buildings and different, types of services, it's, unless they happen to be reared or really understand this, it's going to be a tougher lift. And it's going to be much more difficult than someone who's really on the ground level who can immediately understand the efficacy of the partnership.
That's key, and why a lot of the reason why I pose that question to you all, it really is helpful to have something etched in, not stone, perhaps clay, right? Because these agreements can change from year to year. You build in flexibility so that you can always change and adapt to the needs of the partners or the model over time. But it certainly helps to ensure that what you're getting done and how you're getting it done is easy for anyone to understand, especially in light of staffing changes that the healthcare workforce as well as legal aid are facing right now. You don't want turnover to add a risk to your well-established partnership. Thank you both for taking that on. There is a question in the chat from Haley. Haley, I'm just going to read this out, do my best here, but feel free, raise your hand, let me know if I got it wrong. So the question is, for those that contract with local legal aid organizations, especially if you don't offer compensation or grant funding to the legal aid group, how do you ensure timely data collection on those cases taken by legal aid partners? Haley also mentions, I know our local legal aid groups are really inundated with cases and high workloads, but we also have a need to collect data in a timely manner to measure outcomes. This is a really common question and challenge that folks have overcome, but it remains a persistent challenge across various types of MLPs, whether you're health center based or hospital based, with legal aid in particular, given how under-resourced they are and how much demand there is for access to legal services. Jay or Keegan, do you want to take a stab at that? And then we'll close out.
Yeah, I'll be really quick, and then I'll defer to Keegan. It becomes your, if you really want to be honest about this, Haley, it becomes your ticket to a bigger and better project. The data collection is your meal ticket, if you will, to providing that information and feedback, and then outcomes. And outcomes is way too complicated to talk about, but whatever outcomes you're measuring, either very initial or mid-level or ultimate outcomes, our health care, we urge that on whatever frequency or basis is written into the MOU. Our MLPs were required to provide an annual report or a quarterly assessment or whatever it might be. Sometimes I push back because I'm like, hey, we're too busy to do this. But the best product that we ever provided to some of the larger healthcare entities was the annual report, because it was done with such thought and specificity, but yet provided that data in such a way that it went far beyond the one person who might have eyes for that, but all the way up to the administrative level of the highest level of a huge health system. And it really was critical. So yes, it may be a burden. And yes, we do know that these data collection mechanisms, whether through whatever mechanism you're using, a case management software system, or if you're integrated into the EHR like Epic or whatever it might be, but it should be on your absolute to-do list, because it provides you with the greatest support and the most effective means of then bringing it to the next level, or at the very least continuing the sustainability of the project.
Yeah, very quickly, because I know we're out of time. You were not going to get to sustainability without data. I can't imagine that if you go to your health center partner or the hospital, doesn't matter, or the legal organization, that any of them will say that any of their projects happen without metrics, evaluation, accountability. This is, and if that's true for everyone else in the organization, should we really, as MLPers, be saying that we want to opt out? So I think there's lots of time to continue to have this conversation around and thinking about sustainability and funding. But I would challenge everyone to think about where else in either entity is there no expectation of data.
This is great. I want to first thank Jay and Keegan for another excellent presentation. Very soon, we'll probably have our sustainability issue brief from a learning collaborative that was hosted last summer out this spring. So look forward to that, but also in the future conversations and in the toolkit, we do begin to talk about sustainability. So thank you, Jay and Keegan, and thank you to everyone who attended today for engaging in a really robust conversation about the legal services and how to staff that component of your medical legal partnership. Please take a moment to fill out our evaluation survey, and certainly join us again on March 28th, where you'll hear from lead faculty Keegan Warren about what everyone asked, how do you fund this? Well, actually, we're going to help you figure out how to budget it first before we dive into how do you get the funding to pay for it. So please take a moment and let us know if we did well today and how we can continue to improve. We're going to close out now, and thank you once again. Thank you, Keegan. Thank you, Jay. Thank you, Rehan. Thank you to the audience members. Everyone have a great one. Take care.